A very warm good afternoon to everyone. Myself, Dr. Ronak Gandhi. I am working as assistant professor in Department of Endocrinology at Jodhpur, Rajasthan. So here we are again for a very exciting session of Endocrine Society of India Facebook Live. So today we are going to discuss about another topic, another thing about the hormones and endocrinology. So as we all know, Endocrine Society of India has been conducting these kind of awareness sessions for a few sessions have been done over a period of a few months. So today is another such session. As we are starting with the new month, so we have got a new theme for the upcoming month, the December month, that is the hormones in children. So children cannot be considered as simple as small adults. Children are very different. Children are, I must say, opposite to adults. There are similarities, but at times they are opposite to adults. So, and the hormones do play a major role in their growth and development. Similarly, the role of hormones is a different story in these children. So, we have got that today we'll be discussing similarly a different topic, different thing, different hormones in children. So, today's topic will be about the puberty in children, the normal and the abnormal. To discuss about the puberty in children, we have our expert panelists. So I would request our first panelist, Dr. P. Ravikumar sir. He is Associate Professor in the Department of Endocrinology at MKCG Medical College and Hospital, Barampur. I welcome you, sir.
Thank you, Dr. Ronak.
Second panelist, we have Dr. V. Sri Nagesh sir. He is Senior Consultant Endocrinologist and Diabetologist at Sri Nagesh Diabetes Thyroid and Endocrine Clinic at Toli Chowki, Hyderabad. Warm welcome to you, sir.
Thanks, Ronak, and hello, viewers.
Next, we have Dr. Deepak Gupta, sir, who is Senior Consultant of Endocrinology at Eternal Hospital, EHCC, Jaipur. A warm welcome to you, sir.
Thank you. Thank you, Ram.
And to the last panelist, we have Dr. Debaditya Das. He is a Senior Resident, Department of Endocrinology at PGIMR SSKM Hospital, Kolkata. Welcome, Dr.
Hello,
Debaditya.
sir. Thank you, sir. Hello, everyone. Good evening.
So, as we are going to start a new session and we have a medical session coming up, so I would like to put out a disclaimer. As we are going to discuss a medical topic, so we might use a few terminologies in of medical origin. There might be the terminology of kind of that they are relating to the medical terms. So I would require the discretion by the viewers that these terminologies may be used and they are just used or they are specifically used for the awareness of the public and not otherwise, and they should not be taken as medical advice otherwise also. So starting with our program for the today, I would request Dr. P. Ravikumar sir to have his opening statement about the children, hormones in children, specifically about the puberty. Over to you, Ravi sir.
Yes. Thank you, Dr. Ronak. First of all, I welcome all the viewers on behalf of Endocrine Society of India and all our panelists to this wonderful program of ESI. Today's topic is on puberty, both the normal and abnormal. So, what do we mean by puberty? Puberty is a critical stage in the life of a girl or a boy when the girl or boy is matures into an adult. So, we can say that during this critical period, the children will acquire the sexual maturity and reproductive capability. So during this period, so in other words, to say that the children, a boy becoming a man and a girl becoming a woman, it is in the process of transformation or transition to that state. It is a very integrated, very calibrated period during which takes place the role of various things which comes in for this puberty to occur. So one of the important reasons why we are discussing is because the public awareness on puberty is very, very important. Three important things: the initiation of puberty, the timing of puberty, the maintenance of entire duration of puberty, and into adulthood depends upon various factors. There are many factors. The chiefly these being one of the important factors is the nutrition that is very, very vital. Second is the racial ethnicity and racial features they come into play. when the timing of puberty is taking place, and also various hormones they are at interplay to cause this. So today, what we shall be doing is we shall be talking initially about something about normal puberty, how normal puberty happens, what time it happens, how it progresses. Then there are two abnormal states. One is when the puberty gets delayed beyond the expected age, then what we call as the delayed puberty. Then there is a stage when the puberty occurs before the designated period, then we call it as a precocious puberty. There are clinical and there are very long-term implications for these diseases and how we proceed these diseases. We have got very good panel, so we shall be discussing, and if you have any queries, we shall be very eager to answer. Thank you, Dr. Ronak.
Thank you so much, sir. Now we are proceeding towards our questions or the things that we need that the public should be aware of. So I'll put my first question to Dr. Srinage, sir. Sir, we
Yeah.
are discussing about the puberty. So what is the puberty and when does it occur normally? What do we how layman can understand about puberty?
To give you a simple understanding of puberty, the very word puberty is described from the Latin word puber, which means adult. Basically, what puberty describes is the process where a child undergoes physical, hormonal, sexual, as well as mental and emotional changes, which enable him to slowly metamorphose into an adult. It is somewhat akin to a caterpillar slowly metamorphosing into pupa and then eventually into an adult. This is precisely what happens. A child is quiescent or he's very quiet sexually and as far as the development of the genitalia are concerned till a particular age. Puberty is the age at which he starts developing these changes. In a boy, these can be the changes which happen, for instance, like development of pubic hair, development of axillary hair, that is hair in the armpit, increase in the size of the testes, which signifies that he has slowly matured into an adult and can produce sperm, and also an increase in the length of the penis so that he can engage in sexual intercourse, which is necessary for reproduction. Also, a gain in height, which is in a majority of situations the first change which can be seen in a child with puberty. Later on, you also develop other changes like development of facial hair, development of beard, mustache, improvement in your musculature, which are all the various changes which deepening of the voice, which signify that a child has slowly matured into an adult. In a woman, this can be breast development, development of axillary and pubic hair, and eventually you reach a stage where you start having your menstrual periods and where you are capable of reproduction. All this time period or this process of changing from a child to an adult is known as puberty. Normally, this happens between the ages of 10 to 12 to 13 years in a girl and between the ages of 12 to 15 years in a boy. In general, puberty in the boy is always 2 years later than what is seen in a girl, and this is one reason why boys are always taller than girls. The average Indian age of a girl's having her first menstrual period is 12 and a half to 13 years. And the age at which a male completes his entire development is usually 15 to 15 and a half years. There can be exceptions, there can be specific problems, and there can be outliers, which we are going to discuss subsequently in this Facebook Live. I think, Ronak, you're not audible.
Sorry, sir. So thank you, sir, for your lucid and crisp answer, sir. I would ask Ravi, sir, that sir, what are the changes usually? What are the sequence or what are the changes that are observed during the pubertal development in a boy and in a girl, sir? Sir, you are muted, sir. Ravi, sir, you are muted.
So the changes which we can describe in girls and boys are two separate ways. So I would say that in girls, the changes starts like this. Initially, there is a rapid development, initiation of increase in the height. Number two step will be there is a breast development. Number three is pubic hair and axillary hair development. And lastly, menarche. There are times where there can be overlap. For example, somebody who is in the B2 or B3 stage when the breast development is developing, there can be overlapping of the development of the even the pubic hair. So what we are seeing is there is a chronological and sequence of events in the development of a girl from the starting from the initial height increase. Then you have got a breast development. The breast development usually starts with a breast bud, and then slowly it increases in size to an adult breast size. Then you have got a pubic hair that and axillary hair. This usually develops by around 11 to 11.5 to 12 years. It starts developing then, and then lastly you will get the menarche. Usually it develops around 2.2 to 2.3 years from the onset of breast development. There are also other changes which are happening during the puberty in the internal organ also. For example, the vagina, which used to be only 8 centimeters before the puberty, which increases in size to almost 12 centimeters in length. Then there are also changes that occurs in the uterus. In the uterus, what used to be a tubular structure, it becomes a more of a pear-shaped structure, and there are also increases in the length and the diameter. Similarly, there are changes in the ovary. So basically, to say that it progresses over a period of time. Usually, the puberty, the mean age of onset of puberty in case of girls is around 10.5 years, and in case of boys, it is around 11.5 years roughly. There are plus minus will be there. So 11. In case of boys, what we find the changes are, the first thing to notice is the increase in the size of the testes. When we say the testis size increase means the length of the testis is 1 inch or 2.5 centimeters or more, then we can say that it is entering into the puberty. Then we can see that there are changes in the pubarchia, that what we call as increase in pubic hair and axillary hair. This usually occurs around 1 year to 1.5 years after the development of the testicular enlargement. Then you have got increase in the penile length, which actually overlaps with the pubic hair growth also. There are also other changes like deepening or crackening of voice. The crackening of voice, usually the mean age for the onset of this is cracking of voice is around 13 years. In case of boys, that happens around 13 years. And there will be this development of the mustache usually starts from the corners of the mouth and develops to the other parts. Then development of the beard, there is a larynx, there is a scalp, what we call as the Adam's apple, that is very much prominent in case of boys. So there are a series of changes which enables a boy or a girl to be adulthood. So during this it prepares to enter into the adulthood.
Thank you, sir. Uh, my next question I would like to ask to Dr. Deepak Gupta, sir. Sir, when we should suspect or when should we call that the boy or the girl, he or she is getting into an abnormal puberty, or the puberty is not progressing normally as it should be in case of a boy or a girl? How to answer that? How do parents can suspect that?
Yes, as Dr. Ravi already said, the mean age of the puberty is 10.5 year for the girls and 11.5 year for the boys. So according to the Tanner and Marcel, they said it's almost 2.5 year plus minus. That means the puberty age for girls is between 8 to 13 years, and for the boys it's 9 to 14 years. So if the boys develop, the pubertal development is started before 9 years, that is also abnormal. And if he does not develop any secondary sexual character after 14 years, that is also abnormal. So if he developed the secondary sexual character before 9 years, we can say it's precocious puberty. And if do not develop up to 14 years, we can say it's a delayed puberty. As far as the girl concerned, if uh, uh, 10.5, which is the mean age plus 2.5 years, that means if she developed the secondary sexual character before the age of the 8 years, it's a precocious puberty. And for the if she do not develop any secondary sexual character up to the 13 year, it's a delayed puberty. So for the girls between 8 to 13 year is the normal puberty periods, and after that and below that it's abnormal. And for the male it's 9 to 14 years is the normal puberty period. Also there is a isosexual puberty and sometimes it's a heterosexual puberty. So in the heterosexual puberty, if the male boys develop the female characteristic like the Klinefelter syndrome, that is also abnormal puberty. If the girls develop the male like features like the clitoromegaly in the CH, that is also a abnormal puberty. Thank you.
Thank you, sir. So, as Dr. Debadatti, as Debak sir has already told about the delay in the puberty, that if it is delayed by 13 years and 14 years respectively in a girl and in a boy, then we consider it as to be a delayed puberty. So, what are the things that can lead to a delay in the puberty? What can cause this delay in the puberty?
Yes, thank you, Dr. Ronak, for the question. What I would like to say is that the puberty is controlled by a central mechanism. By that, we mean that the puberty starts in the head, in an organ above the pituitary called the hypothalamus, and that signals the pituitary gland, which is inside our head, and from that, hormones get secreted, which controls our internal sexual organs, for girls, ovaries, and for boys, testes. So what happens is this mechanism to start, there has to be a baseline nutrition in the body. So if there is a child whose nutritional status is not well, the child is too thin or is suffering from any kind of an illness which is chronic in nature, which can hamper its nutritional status, then that can cause a delay in puberty. Along with that, the nutritional status, puberty also depends on the familial genetics. So if there is a history that your father or your mother had a delayed puberty, then there is a chance, or delayed puberty or a late puberty, then there is a chance that you may also uh, have a late puberty. So that is, in medical terms, is called CGGP, or constitutional delay in growth and puberty. So the genes and the nutrition part is very important. And if the child, in the third case scenario, if the child is on some medicines for any other disorder, say a disorder called nephrotic syndrome, where the child may be on a certain medicine called steroid for a long time, or any kinds of medicines which are of the opioid class for any other systemic illness or any other cause. So though these things can also cause a delay in puberty. So if these three things are ruled out, then there are some organic problems, or what to say, I mean, some problems with which involve the pituitary gland, from which is where the puberty starts, and or the some problem with the internal sexual organs, that are the gonads, with which can cause delay in puberty. So in those cases, before going into the evaluation for the origin of this delay, we have to rule out certain other hormonal imbalances, like uh, too less of thyroid hormone in the body, or an excess of a hormone called prolactin. If these are there, these can also cause a delay in the pubertal development. And if these are not there, then we go and find out whether this delay is due to a dysfunction or a malfunction of the pituitary gland in the central nervous system, or is there any problem with the internal sexual organs, for girls ovaries, for boys testes. So these are broadly the causes of delayed puberty, and how, as doctors, we should approach step by step, and also for the general public, what they should know about the causes of delayed puberty.
Great, Dr. Debadatti, great answer. So, we have discussed about how we can have the delayed puberty. So, Nagesh sir, I have this query is pertinent here. That do we need to see as every delay in the puberty to be the organic cause, or there should be some kind of disease within the boy or the girl? If the person is not having a normal pubertal development, then should we think that there must be a problem, or it can be a normal variant also? Sir, you are muted, sir. Nagesh, sir, you are muted, sir.
So there are quite a few variants even of normal puberty. We have what are known as normal variants of puberty. They can be both delayed variants, or they can be early variants also. What was earlier described by the previous speaker, we have what is known as constitutional delay in growth and puberty, where at least one parent in many cases will give us a history of having had a typical delay in growth. Example of this kind of a patient is somebody who describes that they did not grow till they were in their intermediate or their 11th class. They were shorter than the rest of their classmates. They suddenly started growing at around 15 to 16 years of age. And in 2 years, they completed their growth. They entered into puberty and they had a height which was somewhat similar to their peers, maybe slightly shorter than the rest of the class, which could be considered a normal height. This is one variant which is a constitutional delay in growth and puberty. It is a very benign variant and it is perhaps the commonest differential for a delayed puberty. It is very difficult to differentiate it from a delayed puberty. We do not really need to intervene in constitutional delay in growth and puberty, while as we'll see later on, we do need to treat delayed puberty. But clinically and at many times, even medically, we find it very difficult to differentiate. And the only way we can actually differentiate this is follow up the patient for a prescribed period of time and intervene as and when necessary. Then we have other variants where there can actually be a suggestion towards onset of early puberty, but which does not really happen. A classical example is what is known as premature pubarchy or premature adrenarchy. When the child develops pubic and axillary hair, that is hair in the armpit, before the ages of 8 years, this can be a precursor to the child actually entering actual puberty, or sometimes the child will only develop pubic and axillary hair at around 7.5 years. Then there is no further progression of puberty. There is no increase in the size of the testes or an increase in the fertility. There is no increase in the breast. And the other changes of puberty will happen normally at around 12 to 13 years of age. This is very classically described and is again a very minor variant. The only thing we need to do is just keep the patient on regular follow-up every 3 to 6 months. Keep monitoring their gonads and their genitalia to see how they are progressing. And if there is no further growth, we just wait and watch. Another variant which is very commonly being presented nowadays is what is known as premature thelarchy or premature development of the breast. This can either be a just isolated breast development, or in a few cases, this can be a precursor to pubertal development. This is something again which needs further evaluation. We have to look at the bone age of the child. We have to look at the uterus size, and we also have to look at the hormonal levels. And if these appear to be prepubertal or what is normal for a child of that particular age group, we do not again interfere. We just wait and watch. And if this shows any signs of progression, then we test the child further. And if needed, there are specific and good treatments for slowing down the delay, slowing down the progression of puberty. This is just like what you do when you're watching a movie and you freeze it. You just give them an injection. It freezes the puberty at which particular stage it is right now. Then you continue giving this child injections every month or every 3 months for almost a couple of years till the child reaches an age of 11 or 11.5 years, or in some cases till 12 years of age. Then you again stop giving this injection, and the child will again take off from where it had stopped earlier and can have puberty within normal development of puberty from that point of time. But again, this is something which needs clinical judgment. We have to follow up the child. A third variant, which is not classically described even in a lot of medical resources and textbooks, is what is known as premature exaggerated thelarchy. This is something which is in between the very common normal premature thelarchy, where you only have breast development, and the true precocious puberty, where the child progresses very rapidly to puberty and has menstrual periods around 10 years of age. In premature exaggerated thelarchy, even though you have breast development, you might have slight increase in size of the uterus. You might have a slight increase in the bone age. A child whose actual chronological age is 8 years can have a bone age of 9 to 9.5 years. And sometimes even the hormonal levels might be slightly elevated, though they might not be typical of what is seen in a child who is entering puberty. This is a stage which is between the benign stage and the actual precocious puberty stage. This has more chance of progressing to the pathological precocious puberty. And this is where we need to follow up the child more aggressively. And at the earliest sign of progression to precocious puberty, we need to intervene and treat the child. These are the typically seen normal variants of puberty. The reason we are focusing so much on these normal variants of puberty is only to keep the child under observation, but at the same time, we have to exhibit restraint and ensure that we don't treat every single child who comes to us with the least signs of puberty. We only need to follow. Our emphasis is on following up the child and intervene and treat as and when required, because treatment also has its own problems and its own emotional burden and financial burden on the child and family.
Thank you, sir. Thank you very much for this answer. That the patient or the child should be kept in follow-ups in these kind of such normal variants of puberty, where the endocrinologist's follow-up is very essential. So my next question to Ravi sir, sir, how an endocrinologist is important in the evaluation of puberty? How endocrinologists do evaluate for the puberty, delayed pubertal development in a child, in a male or female child? How the endocrinologist role is there? How it helps?
Yes, endocrinologist role is to find out whether it is, as my previous speaker has told, Dr. Nagesh, that whether it is a normal variant or it is an abnormal variant where we require to treat these patients. So the thing is that in these patients, we must know that what are the different causes before you proceed to evaluation of these things. Now, the first and foremost cause is one of the, as has already been discussed, is the CDGP, or what we call as constitutional delay in growth and puberty, which is nothing but a normal variant. It is only just a delay in the normal course of events in a in CDGP. So that is a number one cause. Number two cause is some of the hormones which are secreted from the pituitary and hypothalamus. If they get delayed or there is a decrease, then the puberty can be delayed or it may be even absent also. So these are the, and there are various chronic diseases. These are the first, second, and third. These are the three important things which comes to mind when we deal with such type of patients. So how an endocrinologist proceeds with in evaluation of or examination of these patients? The first and foremost on three basics. One is history. We ask certain questions to the patient. Number two is we examine certain findings. Then we do the certain test, that is hormonal test and other test, to find out what is the real reason for this delay in the puberty. So in the history, we take that what is the child's birth, how the child was, normal milestones of development, whether the milestones of development were normal or they are delayed, whether the boy is much shorter in the class or he is the taller in the class. That also very important. And is there any chronic illness? Is there any history of any liver, kidney, tuberculosis, or any disease or recurrent respiratory tract infection, which is very common in children, or recurrent diarrhea? These are all they can delay in the onset of puberty. So history is very vital importance in determining whether there is any chronic illness is there or not. The other important history we must take in these patients is history of absence of smell. That is anosmia, that is very, very important in this type of patients, and history of any head trauma or any neonatal birth injury, especially in the form of breech delivery. So such type of history is very important in patients with, in such type of patients. Number two part is, while examining the patients, we first see for whether there is any features of secondary sexual development are present or absent. In case of boys, we see that whether there is any temporal recession is there, whether there is any beard or the mustache has appeared, any testis development is how it is, the penile length is how much it is there, and the pubic hair and axillary hair we will examine. Similarly, in case of girls, we examine the secondary sex characters like the breast development, the labia majora, labia minora, and is there any ambiguity or not. Besides this, there are certain measurements which we usually do, what is known as the arm length and the height. If the arm length is more than 5 centimeters more than the height of the child, that means the patient is, the boy or girl is unicoidal proportion. That means the hormones which are required for the normal puberty, they are not acting the way they should act. Then we should also test like whether there is any smell is there or not. This is very important because if the smell is absent, it specifically indicates certain diseases, but absence of certain hormones, especially from the pituitary gland and from the hypothalamus. So we must focus on that. Besides this, various, suppose somebody is having rickets, there are certain clinical features which we see, what is known as the rickety rosary. So there are certain we have to examine the patient. Number three is the hormonal investigation. In the hormonal investigations and other investigations, first we have to rule out the general conditions, like we do the hemogram to see that whether there is anemia is there or not. We see the thyroid function test, whether there is any hypothyroidism or hyperthyroidism is there or not. Then specifically in boys, we do three important hormones, the LH, FSH, and testosterone. And in case of girls, we do LH, FSH, and estradiol. This broadly gives you an idea that whether there is a hypogonadism is there or not, whether the hormones are normally synthesized in the body or not. That gives. Besides this, nowadays we are also doing so. This gives you roughly an idea whether the child is likely to develop the secondary sexual characters in the next 1 year or 1.5 years. Roughly, it gives an idea. Suppose some where the testosterone or the estradiol is very, very low, it is very likely that these patients might be hypogonadism is there, and probably they require treatment. Besides this, nowadays we are also doing certain tests like inhibin B and AMH. These are the upcoming. Inhibin B is now part of routine investigation, which we are doing in all patients with delayed puberty. There are various cutoffs, which of course is very much important for us. If the cutoffs are less than their particular value, then it is very likely that the patient requires long-term treatment in these patients. So evaluation proceeds from history to the clinical examination to the finally it is concluded with the various tests which we do.
Thank you, sir. Thank you for that extensive elaboration of the all the things that we do, we as endocrinologists do. Uh, my next question to Dr. Deepak Gupta, sir. Sir, as we have already discussed that delayed puberty can be at if it is pathological or if it is due to some organic cause. The causes being lie in the two of the etiologies, major etiologies, either the pituitary or into the gonadal area. So in the boys, there is a major cause of delayed puberty is considered to be a Klinefelter syndrome, which is very much common and unknown. And the other is hypogonadotropic hypogonadism. Sir, can you elaborate a bit few differences among these two things? What are the differences and how they present in the normal population when we can suspect them?
Yes, as already Sir said, we can divide the hypogonadism into the hypogonadotropic hypogonadism or the hypergonadotropic hypogonadism. So the Klinefelter is hypergonadotropic hypogonadism, where the LH and FSH is higher and the testosterone is lower side. While the hypogonadotropic hypogonadism, where the LH FSH is lower side and testosterone also lower side in the male and estradiol is lower side in the female. So there is although there is some specific criteria where by the clinical examination we can differentiate, but sometimes it's difficult. So the hypogonadotropic hypogonadism patient generally have, as Sir said, they have a unicoidal proportion where the arm span is more than their height, almost more than 5 or 10 centimeters. They have a history of a taller child in their school age peers. They have a small and soft testes, and testis size is generally below 4 centimeter. They also have a micropenis. Sometimes they have a cryptorchidism, and sometimes they have a uh, other pituitary hormone deficiencies. Sometimes they have a midline defect. Sometimes the micropenis is also there. But in the Klinefelter, they generally almost 75% of the Klinefelter patient are remain undiagnosed. The mostly they diagnose in the trimodal phase in the intrauterine period, where if the patient goes in the intrauterine karyotyping, that time they can diagnose, or in the childhood period, where if the child have a docile behavior, learning difficulties, or sometimes delay in the speech, and also the cryptorchidism and the micropenis is also feature of the early presentation of the Klinefelter syndrome. But in the mostly in the adult age group, they present with the azoospermia. So they come for the infertility, and they found that they do not have any sperm. But the clinical feature, as far as the Klinefelter syndrome, they also have a long limb, and they have a small and the firm testes, while the hypogonadotropic hypogonadism have a small and soft testes. And also they have a good canal length, because they have a pivotal arrest as compared to the hypogonadotropic hypogonadism, where there is a no puberty. But in the Klinefelter syndrome, they have a sometimes some testosterone level also, so they look like male, but sometimes they have a some beard also, but mostly have a without beards. So these are the clinical symptoms by which we can differentiate hypogonadotropic hypogonadism and the Klinefelter syndrome. But mostly patients are required investigation like the LHFSH and testosterone estradiol respective sex.
Thank you, sir. Thank you very much, sir. Dr. Debadatta, can we have a word from you on how do we treat the cases with delayed puberty? What do we do? And are there any side effects that should we be aware of these medical treatment that are being given to these kind of patients, these kind of children?
Sure. To summarize the treatment of delayed puberty, I would like to say that first of all, the cause of delayed puberty remains important in the treatment. So, if there is a history of delayed puberty in the family, we may not treat it if we are diagnosing it as a familial or a constitutional delay in growth and puberty. We just can wait and watch. Sometimes a very short course of artificial sex steroid hormones like estrogen for girls and testosterone for boys are given to just kickstart the puberty, after which it picks up its own course. If the cause for delayed puberty is undernutrition, then of course you have to correct the nutrition. No need for any other medicines. If the cause for delayed puberty is any drug medicine which is being used for a long time, in that case, to alter the medicines, use some other medicines so that the puberty can get on its way, can be done. If there is a problem with too low thyroid hormone in the blood, then a thyroid supplementation can kickstart the puberty. And if there is a problem with the excess of a hormone called prolactin, then addressing that cause will help us in treating the delayed puberty. Now, if these causes are already addressed and these are not there, then you find out whether the problem is in the head or the pituitary or in the gonadal organs, the internal sex organs. If the problem is in the pituitary or the hypothalamus just above the pituitary, then there are two options to initiate puberty. One is by giving the sex steroid hormones, estrogen for girls and testosterone for boys, or you, instead of giving the end product, that is the sex steroid hormones, you can start your treatment with some artificial gonadotrophic hormones, which mimic the endogenous natural hormones that are secreting from the hypothalamus and pituitary, which can go and act on the internal sex organs, namely the ovary and testes for girls and boys. So both options are there, although the end product, that is testosterone or estrogen for boys and girls, are comparatively cheap. And if the problem lies in the gonads, like sir discussed about Klinefelter syndrome, where the testis is not formed well, or any other syndromes, for say Turner syndrome in girls, where the ovaries are dysgenetic or dysfunctional, to say, in those cases we may use the sex steroid hormones only to so that the pubertal features, that are external pubertal features that are there, can develop. So in a nutshell, these are the options that we have. If I summarize, these therapies are mostly safe. You do not need to worry a lot about these therapies. uh, Certain checks and balances needs to be done, which your physician will of course do. So as a whole, I would say that the therapy is usually safe and very efficacious.
So thank you, Debadatta. So Nagesh sir, we have discussed lot about delayed puberty. So there is also precocious puberty, as we have already discussed that there can be an earlier onset of the pubertal development. So are there any kind of disadvantages with early puberty? If the child undergoes an early puberty, what can be going wrong? Sir, you are muted, Nagesh sir.
With early puberty, there are two major disadvantages and one minor disadvantage which we are discovering now. The most major disadvantage that any girl or boy can have with an early or a precocious puberty is that the final height is going to be shorter, because this is how height proceeds. At birth, any child will be 50 centimeters of length or height, grows 25 centimeters in the first year of life, 12.5 centimeters in the second year of life, and subsequently every year the child is growing to grow at 6 centimeters per year till the attainment of puberty. So if you are going to have your onset of puberty at 7 years instead of at 10 years in case of a girl, your puberty in either a boy or a girl is going to be there only for 2 years. So instead of starting your puberty at the age of 10 years and ending it at 12 years, if you start your puberty at the age of 7 years and end it at 9 years, you are going to lose 6 centimeters per year of height. So whatever 6 centimeters per year height gain you would have had from 7 years of age to 10 years of age, and then onset of puberty at 10 years of age is now cut down from puberty at 9 years of age. So 3 into 6, you are going to lose approximately 18 centimeters of height. The same holds true for also boys. The number of years of age you have puberty in advance of your actual age of puberty, you are going to lose so many years of 6 centimeters per year of height. And this is actually going to translate into short stature. And this is the most important reason why we always try to treat children with medications which will arrest their pubertal development so that they can continue to grow at a prepubertal height of 6 centimeters per year till they reach an age at which they can actually have puberty at an age which is commensurate or approximate to what is seen with other children of their age group. If you don't do this, they're going to end up short. They're going to start accelerating very rapidly at around 7 to 8 years of age, have very 2 years of a rapid growth spurt, and end their height at 10 years, as unlike their peers who are going to grow till 13 years of age. People generally have a misconception that boys and girls grow till 18 years of age. This is not correct. You can vote at 18 years of age, you can drive at 18 years of age. Girls can marry at 18 years of age, but you definitely do not grow till 18 years of age. It's usually 13 to 13 and a half years for girls and 15 to 15 and a half years for boys. And if you have your puberty at around 10 to 11 years of age, you're going to lose 3 to 4 years of your growth. And you'll eventually end up shorter than the rest of your classmates. The second problem you have in people with an early puberty is that they're emotionally immature to handle the emotional changes, the sexual changes, the aggression and the sexual thoughts which come at the age of puberty. Because as all of us know, teenage is an age when we have a lot of confusion. Teenage is an age when we have a lot of sexual thoughts. We have a lot of confusion as to what our aim and purpose of life is. And we also have a lot of confusion about our interactions with members of the same sex, as well as, most importantly, with members of the opposite sex. But if you're around 13 to 14 years of life, you're more mature and you're at a stage where you can handle these changes which happen in the life of every person. But if these same changes start happening when you're 8 or 9 years old, you are not emotionally equipped to handle these changes. This can lead to a huge amount of emotional trauma for the child, social maladjustment for the child, and can also lead to a huge problem, adjustment problems for the child, and can also lead to the child being singled out from the rest of her classmates and peers. Having your menstrual cycles, being absent from the class, being advised to take hygienic precautions during menstrual cycles, and all these things are not something which can be handled properly by a girl at 8 to 9 years of age. It can be handled well by any girl at 12 to 13 years of age. 8 to 9 years is not an age at which a normal girl, a very young girl, a juvenile can be handling this kind of changes. This leads, and this has been reported to cause a significant amount of emotional trauma. And this is the second most important reason why we always try to slow down the progression of puberty in children who have precocious puberty at this age, so that they can end up having a normal childhood. The third reason, these are the two major disadvantages which you have with precocious puberty. The third reason, for many years, it was actually assumed that girls who were treated for precocious puberty actually ended up having irregular periods. Many a time, irregular periods in girls with precocious puberty was actually attributed to these medicines called GnRH analogs, which actually arrested your puberty. But as our understanding of these disorders has increased, we have come to know that in a majority of girls who actually have early puberty or precocious puberty, there is something abnormal with their menstrual pattern, both at the level of the pituitary at the brain, as well as the level of the ovary or the ovary. And these women, irrespective of whether they are treated for precocious puberty or whether they're not treated for precocious puberty, tend to have slightly irregular periods all their life. This is a minor problem, and there is nothing much we can do about this in girls who have precocious puberty. This usually does not translate much into problems with pregnancy, but they do tend to have slightly irregular periods as opposed to their peers, and that is why I have called this a minor problem. The major problems, as I can quantify, are short stature or decrease in height, and emotional problems because of early puberty. The minor problem is some of these girls do tend to have irregular periods, though not much of an effect is seen on fertility.
Thank you, sir. Thank you for that elaborative answer. These days, we are seeing that the age of puberty in girls is getting lowered day by day. And I would like to ask Ravi, sir, do you also see the same kind of trends being observed that the age of pubertal start of the pubertal development is getting lowered day by day? And is there any kind of role of sir meat and milk and these kind of products that are being used or that are being used by the children that can cause this kind of phenomena where the ages of starting of the pubertal development is getting lowered down?
Thank you, Dr. Ronak. This is a very important and very pertinent question to ask. Actually, the normal, as we have discussed since beginning, the normal puberty age range in a girls is from 18 years to 13 years, and in case of boys, it is 9 years to 14 years. This is the usual age range for which majority of our population, actually, majority of our girls and boys enter into puberty. So we call precocious puberty when a girl occurring the secondary sexual characters before 8 years, and in case of boys before 9 years. That's what the standard definition. But as we are seeing that some of the kids, especially in case of girls, that the age for the onset of puberty might occur even earlier. But this phenomenon, what we are discussing, this phenomenon is not so much prevalent in our country, although in our country the premature thelarchy, premature puberty are more common compared to the premature or precocious puberty occurring at a very very early as a normal variant is not less common. So in US, in America, various studies have shown, especially in black girls, and in case of when compared to the white girls, the mean age of onset of puberty is much earlier. So one of the studies which took into the age from 3 years to 12 years in the America, they found that if girls, even they can enter into black girls enter into puberty even at the age of 6 years, and in case of white girls, it is up to 7 years. So they said that. So some of the institutes like Lawson Wilkins Pediatric Society, they defined that precocious puberty has been defined in case of girls, occurring in case of less than 6 years for black girls, less than 7 years for white girls. But for all practical, but the same thing has not been observed in case of boys so consistently across the globe. And this is race, ethnicity, nutrition, various other things play into act. One of the, you asked about one pertinent important question, that whether the meat, milk, and other things can be affected with this thing. Yes, because nowadays what we are seeing is that the endocrine disruptors, which are very commonly found that in various as a contaminant, especially the bisphenols and other various other contaminants, which actually disrupt the hormonal sequence and the hormonal activity even much before the age of normal onset of puberty. But I also tell you that there are two other important reasons why this phenomena has been occurred in some other countries, or in also in our part, certain parts of our country. That is because one is the overweight. As the overweight and obesity, actually obesity might cause delayed puberty, but if they are overweight, they are likely to cause the even before the onset of the normal age of puberty. The second important thing is that nutritional status. Previously, what used to be the nutritional status of the girls and boys, where the malnutrition usually causes delayed puberty, but excessive nutrition and normal nutrition sometimes they may cause even earlier in the onset of puberty. So, to conclude, the three important things: one is nutrition, the second is the weight of the child, then the third is various hormones and endocrine disruptors. They're all acting and causing, especially in girls, the age of onset of puberty is occurring slightly earlier compared to boys.
If I might interrupt here and slightly disagree with Ravi Kumar here on one aspect, he's been mostly correct, 99%. But disagreement from our perspective is this varies from state to state. But in our state, we're actually seeing a lot of girls presenting. He's absolutely right in saying that boys are not presenting with this trend. But I've been seeing a lot of girls who are presenting with, I wouldn't call it precocious puberty, but early puberty. Girls presenting with onset of pubertal changes after the age of 8 to 9 years and having their first menstrual period around 10 to 10.5 years. This doesn't exactly fall under precocious puberty, but this does come into a trend known as early puberty. We have been seeing a lot of this in urban areas, especially the metropolitan areas. We've been seeing a huge amount of this in the last 5 to 6 years, especially. And I think this trend is only increasing. And as Ravi has rightly pointed out, the reason for this is obesity, and this has increased by leaps and bounds after the lockdown. When children had a lot of weight gain. After lockdown, it has increased a lot. And we are also going to see more of this in the next 2-3 years.
I mostly agree with Dr. Nagesh. I have just one comment to make. Actually, in case of girls, what we are seeing here is not that much what we are seeing in the Western literature, because we are seeing these cases. As I told, correctly pointed out, it varies from state to state, because India is such a big country, and the nutritional status with the dietary habits are so different. We go from one state to other state. Definitely, we can expect some variations. Definitely. And the other important thing is that this occurring in the boys, actually the menarche has come down remarkably. As I found that the menarche used to be what used to be 14 and 15 years, what our mothers and the elders used to say, that has remarkably come down, actually. But if you see the onset of puberty in case of girls occurring maybe before 8 years or maybe 6 years or 7 years, so that one study has found that only 5% of girls will have secondary sexual characters. Normal girls will have less than 8 years, and puberty less than only 3% of the girls they can have before 8 years. But as I told, Nagesh has rightly pointed out, it varies from state to state. So we cannot generalize to all the things to it. But fortunately, the 8 and 9, I think we can keep it for the time being in our day-to-day practice. Thank you.
And DDT is one thing I think which is being neglected a lot, because DDT is a very, very well-known endocrine disruptor which has estrogenic properties, and India is the world's largest producer and consumer of DDT.
Yes, yes. DDT is one of the container, but fortunately now its use has been remarkably come down actually over the last few years. Otherwise, previously during our childhood, there used to be a lot of uses of DDT for everywhere we used to see the DDT, but nowadays, fortunately, that has come down remarkably.
But luckily, we didn't end up with precocious puberty.
Thank you for this great discussion, faculty, dear faculties. I have a question from our comment section that Suresh Mohapatra has asked: is food and lifestyle responsible for early puberty? We have discussed about food and obesity, so specifically food and lifestyle, they are responsible for early puberty. Nagesh, sir, your take, sir.
Yeah, I'll be very cautious about this because I've had a lot of discussions with pediatricians. Food and lifestyle, food, yes, to some extent, like Ravi has pointed out, use of endocrine disruptors, some people using hormones to boost milk production, and all these factors in meat and milk have been implicated. But you just cannot generalize and say that these are the only reasons why people are having precocious puberty. There are many other reasons. Increased weight and lifestyle changes are perhaps the single largest reason. Many a times I've actually seen parents and pediatricians just going ahead only with dietary changes and not referring the child appropriately to an endocrinologist for further follow-up. They just focus on the food and the lifestyle changes, and by the time they actually come back to us, a lot of these children have already had their first menstrual period. I think this laxity has to end. Food and lifestyle might be responsible, but they are not the only reason why this condition is happening. You have to make changes in your food and lifestyle, but at the same time, you also have to investigate it appropriately. For all we know, it could be secondary to an ovarian cyst. The child could be having a hypothalamic hamartoma. There could be some other problem. The child could have a hydrocephalus. In a male, it could be a testotoxicosis, or even very rarely, you can even have tumors which can cause these kind of conditions. All of this need to be investigated and treated appropriately. And just attributing precocious puberty to food and lifestyle is not the right way of going about
it. Just to add one point here, just is very nicely elaborated by Nagesh. One point just I want to add here, that one of the articles has found that the so-called kisspeptin, what we used to describe, kisspeptin is the initiator of puberty. There are variations in the kisspeptin, either in the gene or its receptor activity. Sometimes it is so covert that it presents as a normal puberty, even in a child less than 8 years or 9 years in case of boys and girls. So that has been one of the observations has been done in certain studies. I think that may be useful for our research in future. Thank you.
Thank you so much, sir. I would, we have discussed at extent about the disadvantages of puberty and why it is getting lowered in the children. Uh, I would like to ask to Dr. Deepak Gupta, sir, what are the common causes that a layman should be aware of that can cause precocious puberty or early puberty in their children?
Yeah, thank you, Dr. Rana. The most part is already we have discussed. The precocious puberty, the food and obesities already have some role. And also we know we can divide the precocious puberty into the gonadotropin dependent precocious puberty or gonadotropin independent precocious puberty. Gonadotropin, as already Dr. Devada said, it's secreted from the hypothalamus to the pituitary and then the gonadal axis. So if we have a problem, hypothalamic hamartoma, if we have some tumor in the like the astrocytoma, optic glioma, that time, or sometimes if we have a meningitis, encephalitis, head trauma, or the birth asphyxia, or some cyst in the pituitary and the hypothalamic region, that can develop the gonadotropin dependent precocious puberty. And now the second one is the most commonly seen is the gonadotropin independent precocious puberty. So as far as the boy is concerned, the congenital adrenal hyperplasia is also a common cause. Sometimes there is a uh, uh, SCG secreting tumor, although it's not so much common. Leading cell tumors, that is also a cause of that. Familial testotoxicosis is also cause. Sometimes their exposure to the androgen is also cause of the precocious puberty. And sometimes there is a McConney-Albright syndrome is also cause of the precocious puberty, which is the gonadotropin independent precocious puberty. And sometimes adrenal tumor is also cause of the precocious puberty. And sometimes there is a primary hypothyroidism that's also should be ruled out in every patient. If there is a no growth spurt with the secondary sexual character, that time the hypothyroidism is the major cause. As far as the girl concerned, the precocious puberty is due to the same gonadotropin dependent reasons from the pituitary and the hypothalamus, and the other the ovary lesions like the ovary cyst, ovary tumors, that can cause also the precocious puberty. Also sometimes there is a McConnell-Albright syndrome, or sometimes there is a estrogen exposure that can lead to the precocious puberty. And sometimes also there is a isolated premature thelarche and the menarche, which do have a slightly higher estrogen level but do not have a classical precocious puberty.
Thank you very much, sir. Dr. Debaditya, we have discussed about the precocious puberty, how we are going to divide the causes and everything. So, do we need to treat all the cases of precocious puberty irrespectively of any other factors, or we need to screen them and look after it? We need to treat only those such cases, and we need not to treat such cases. That kind of segregation is possible. And do we treat with what we treat them with? Is there any important side effect that we should be aware of, or we should make the patients or the attendants to be aware of those kind of side effects when we are using these kind of drug medications like puberty blockers or anything? Then anything that we should be aware of?
Yes, thank you for that question, Dr. Ronak. I would like to say that if a child presents with a very early puberty, then it definitely should be treated. If the child presents at a later age, say at around 8 years for girls or at around 9 years for boys, then the treatment may be individualized, because the main reason that we treat a child with precocious puberty is to preserve the height that the child has the potential to achieve. So if the child has come with history of precocious puberty but has crossed a certain limit of age, then the treatment might be futile regarding the height gain. But yes, another cause of treatment of precocious puberty is to delay the puberty so that the child can be emotionally mature enough to handle the bodily changes that are happening in the child. So regarding that case, all the precocious puberty can be treated. And also regarding the treatment, the puberty blockers, so to say, that we discuss about, they are usually generally safe, and it can be given, although there were some concerns regarding, like Dr. Srinagesh discussed, of having some PCOS like symptoms later in life, or some concerns with bone maturity. But in general, the current knowledge tells us that these concerns are actually overhyped, and puberty blockers can be easily used. Overall, the advantage of using the puberty blockers to delay the puberty to an appropriate time outweighs the whatever minor disadvantages that might be there. Regarding the type of puberty blockers, what medicines to be used will be dependent on the type of precocious puberty. If there is any problem with, say, the thyroid hormone, which is causing the precocious puberty, then the thyroid supplementation is enough. No need to give any other puberty blocking drugs. If the problem is in the central part or in the brain, the pituitary hypothalamus complex, in that case we usually give monthly or 3 monthly injections of puberty blockers, which actually helps us in managing this precocious puberty. And if the cause is somewhere in the gonads or the adrenal gland, that is the peripheral cause or gonadotropin independent cause of precocious puberty, in that case the management is specific for specific disorders. Like for CAH, we usually, or congenital adrenal hyperplasia, we usually manage with steroids, and for other things the treatment can be different in boys and also in girls. In general, yes, precocious puberty should be treated, especially if they're presenting at an early age, and the treatment benefits hugely outweighs any potential risks that are discussed. Thank you.
Thank you, Dr. Debaditya. I would like to have a question for Ravi sir. There are a few cases where the newborns who are born after just the birth, they usually have a female child, or there would be a bleeding from the genitalia, the genital organs. Then, sir, should it always be concerning to the parents about the precocious puberty, or it is a normal variant?
Actually, the parents get very much worried once they see the bleeding per vagina. They get actually very scared of actually. But it is a very normal phenomenon which occurs because of the placental transfer of estrogens when they get from the maternal side. Once they decrease, then there occurs a withdrawal bleed from the per vagina. So that is not to be taken very seriously in these cases. This is a very normal phenomenon which subsides on itself. We don't have to intervene in these cases. We have to just observe these cases, whether it repeats or not, or whether it persistently present for a long period of time. Then of course we need to be concerned about it. Otherwise, usually it subsides by next 2 to 3 4 days. It usually subsides, and the parental anxiety and worry is very much there in these cases. We just have to assure them that this is a normal variant. They don't have to worry for these cases.
Thank you, sir. Thank you, sir. I would like to ask Dr. Deepak Gupta, sir. Do we this thyroid function we have discussed that the thyroid has got some role in the pubertal development and everything, sir? So this thyroid is going to affect how it is going to affect the pubertal development. Is it going to delay the puberty, or it is going to accelerate the puberty, or what? What is the role of thyroid hormones there?
Yes, very important. Any precocious puberty or delayed puberty, when we investigate thyroid disorders, should be excluded first, because the hypothyroid can develop the precocious puberty also and the delayed puberty also. Thyroid hormone required for the every cells. So if someone come with the thyroid disorders and have a precocious puberty and delayed puberty, do not investigate for the other. First, we have to treat that, and if the thyroid function is normal, then the patient have a precocious puberty, then we investigate for the further test. But definitely, in the if we see the hypothyroid patient with severe hypothyroid with the precocious puberty in the girls, there's LH is suppressed, FSH is also slightly suppressed, and the estrogen is slightly high due to the ovarian cyst, and the bone age is also delayed. But in the male, is same features are there, and there is a testicle enlargement there. There is a no penile enlargement. There is a no height velocity is seen. So discordance of the pubertal development sequence, discordance of the sequence of the puberty is seen in the thyroid disorders. So definitely we should rule out first the thyroid disorder before the other workup of the precocious puberty and the delayed puberty.
Thank you, sir. Sri Nagesh, sir, there is a role of extreme exercise and pubertal delay. So, is there any link, or it is just a made-up thing, kind of thing that puberty can be delayed? So, you are muted, sir. Sir, you are muted, Nagesh, sir.
This is actually a very well-known entity which is seen in athletes. This is what is known as hypothalamic amenorrhea, which is classically seen in gymnasts, long-distance runners, and ultra-marathon runners. Because of certain unknown reasons, not very well-described reasons, part of it is because of hypothalamic suppression due to extreme exercise, and also because of absolute lack of fat in these women because of extreme exercise. These women do not generally start having a normal progression of puberty. Even if they have had normal menstrual cycles till date, the minute they take up this extreme exercise, their menstrual cycles start slowly becoming irregular, and then they eventually stop having menstrual exercises completely, and they are restored only after they stop these exercises, and then they again start having a normal diet and have a normal amount of fat development in the body. Because generally, in a lot of situations, you need a critical amount of weight before you start having a normal menstrual period. Even if when you evaluate these women, classically you will elicit a history from them that they exercise for almost 3 to 4 hours a day, or they go in for extended bouts of extreme physical activity. Second, a lot of them, even if you examine them physically, will have some amount of breast atrophy. They'll be very lean. Some of them will have the cortical hair, part of it would have been converted into lanigo hair. And they have changes which are very similar to what is seen in somebody with an anorexia nervosa, even if these women tend to eat normally. Pretty similar to what you'd be seeing somebody with anorexia nervosa or eating disorders. And even if you look at the hormonal levels of these women, you'll actually find out that the LH and FSH are usually quite low in these women. The only treatment for this is to ensure that they start cutting down on their exercise, and they tend to gain more weight. Many studies have actually shown that a critical weight below which you are unlikely to have any kind of menstrual activity lies somewhere between 30 to 35 kilos. Below this particular weight, you are unlikely to have any kind of hormonal activity in your body, because a lot of your sexual hormones are actually derived from steroids and fat. This is very much described, and if there are people out there who are going into extreme exercise, I think you should watch out, especially if your menstrual cycles are irregular.
Thank you, sir. Thank you very much. Dr. Debadatya, can I have a very short comment of yours on genetic test? Are they helpful in patients with abnormal puberty, in children with abnormal puberty?
Yes, they are helpful. There are a set of candidate genes that has already been discovered, especially in cases of delayed puberty that has its origin in the pituitary or the hypothalamus. So, and the one more thing is that they are usually in the form of a syndrome. So, usually delayed puberty may only be a part of it, and there can be some other parts of that syndrome which has not manifested yet. So, actually, this finding of delayed puberty can give us a clue or an opportunity for this genetic testing, which can actually tell us what might happen to the child in case a syndromic gene is discovered in the genetic testing. Similarly, for precocious puberty also, there are certain genes that are implicated, less so than hypogonadotropic hypogonadism or delayed puberty. So yes, there is of course utility of genetic testing, and that can give you a prognosis how the child may behave, and that can help you individualize the treatment.
So the genetic testing can help in individual cases where we are suspecting of a syndromic causes. There can we have the genetic testing, and we can proceed further for the prognostication. So we are coming to the conclusion of our very interactive, very discussing session on the abnormal and the normal puberty. So I would like to have closing remarks from all of the panelists. So starting from Devadatya, your closing remarks, Devadatya.
I hope that we were able to educate the general public somewhat about what are the normals and what are the abnormals regarding the pubertal development, so that they are more aware and they can seek help earlier, go to a pediatrician if needed, get referred to an endocrinologist. So that was our motto regarding today's talk, and hopefully we actually served well for the day. Thank you.
Dr. Deepak Gupta, sir, please.
Yes, Sam here. If we see any abnormal secondary sexual character, early age or late age, consult your doctor. And if definitely if you have a endocrinologist nearby you, consult your endocrinologist so they can take action early, and definitely you will get the benefit. Thank you.
Nagesh, sir, your comment, sir.
My comment is pretty brief. Don't panic because this is not a life-threatening disorder, but don't neglect. Don't delay in consulting your endocrinologist, and most important, be aware of the actual ages. Any puberty which is delayed after the age of 13 is delayed. Any puberty before any changes before the ages of 8 to 9 years is early. Know the correct ages. Don't panic, but don't neglect.
Thank you, sir. Ravi, sir, your expert comment, sir.
Yes, because after extensive discussions, I think we have imbibed some knowledge into our general public. The most important thing about endocrinology is once we diagnose these cases, the treatment, the beauty is that we have got excellent treatment to see that the major benefit to the patients. So patients get actually real benefit once you diagnose and treat them appropriately. So they will be very happy, and we can advise them about the correct sequence of events and the follow-up. It will be very useful. So the beauty of endocrinology is that we have got treatment for almost nearly more than 90% of cases we can appropriately treat and give the satisfaction to the patients and parents.
Thank you so much, sir. Thank you to all the panelists. And in the similar fashion, we will be having a similar session of Endocrine Society Facebook Live awareness program on 10th of December regarding the thyroid and the hormones in children regarding the thyroid function and dysfunction. About the next event that we are going to have in the January month, the Endocrine Society of India, along with Indian Thyroid Society, will be organizing the thyroid during the January month, which is considered as the Thyroid Awareness Month. It would be my proud privilege to invite you to a month-long daily public awareness program, which aims to address the questions on all aspects of thyroid disorders. Endocrine Society of India and Indian Thyroid Society, they are jointly going to organize this event. Facebook live sessions there will be on each day of the month of the January, during the month of the January, from 7 p.m. to 8 p.m. and they will be starting from 3rd of January 2023 and will continue till 30th of Jan. So, and the USV will be the academic partner for this event, for the month-long event. And I humbly invite everybody of you for that session on the Facebook Live program. Thank you very much, and good night to everyone.
Thank you.